Welcome to our next presentation in the online NCD course, where we talk about the prevention of diabetes. And as a subtitle I chose from global impetus to national solutions. This presentation again is split into two parts. In the first part we talk more about the general features of prevention. Of course, and we use and apply to diabetes, but much of it applies to all NCDs. And in the second part, we then specifically look at diabetes type 2 prevention interventions. What are their barriers and obstacles? What are the single components for those prevention programs, etc., etc. So let's get started with part 1. Let's talk about prevention strategies first, because I'm referring quite often when I talk about prevention to more than only a prevention activity, but a whole strategy. And I use again the dictionary of last dictionary of epidemiology to define what is a strategy. And there it says it's a set of essential preventive measures believed sufficient to control a health problem. And it's also worthwhile highlighting that the word prevention embodies the goals, the ultimate goal of medicine: to promote health, preserve health, to restore health when it is impaired, and to minimize suffering and distress. We come back to that goal of our activities. Before we go into preventing something, of course we want to know, is it worthwhile? Is it a big enough problem? And I think we all agree, but it's nice to review the magnitude of the diabetes problem. And I pulled out this old statistics from 1997, where WHO estimated that the number of people with diabetes will nearly double within the first quarter of this millennium. So it should go from about 150 in the year 2000 to almost 300 million people with diabetes in the world. Now, in order to get the latest update, I would recommend you to go to the website of the International Diabetes Federation. So here under www.idf.org you get a diabetes update straight from the International Diabetes Federation. Let's have a look what we find there. We find there a summary of the Diabetes Atlas in its 5th edition, and it's actually the 2012 summary with a lot of interesting regional but also country statistics. Remember the predictions from 97 WHO that diabetes would reach 300 million by 2025, and what are the current estimates from IDF? You see here on the Diabetes Atlas it is 371 million people living with diabetes, 50% estimated to be undiagnosed, a global prevalence of 8.3%. So much higher than what was predicted to be reached only in more than 10 years into the future. So have a look at this website, download this interesting statistics, but also I like to direct your attention to what you get also from the website, and that is an Excel spreadsheet of country estimates. You can actually look up country by country the number of diabetes cases, the national prevalence of diabetes in adults, and what you don't see on this sheet is you can compare that to the 2011 prevalence data. Very interesting and useful resource. Now, why is the prevalence of type 2 diabetes increasing so much beyond the projections and best estimates we had only 15 years ago? One factor is certainly the aging of the population, and if you recall the publication of last year about the global burden of disease, that is a key driver of increasing prevalence of all NCDs, not only diabetes. Another factor certainly is the increasing incidence due to global trends in lifestyle transition, especially pronounced in developing countries. Lifestyle from being more suitable to health in terms of chronic disease prevention to a lifestyle now which has a lot of features bringing up obesity and other metabolic disturbances leading to diabetes and other NCDs. And that actually is occurring globally, and if you look at the increases in diabetes, there's not a single region in the world spared of that increase. So more sedentary urbanized lifestyle and a transition in our nutrition occurring also globally. Let's look at the factors associated with diabetes type 2, because once we agree on those factors, then we can design around them our prevention interventions. And one good distinction is to group them into non-modifiable and modifiable factors. And amongst the modifiable, I have actually two groups: the more proximal, closer to home, so to call factors, and the more distal one. So the non-modifiable factors, we can be rather cool about it. Those are genetic factors, demographic factors such as age, ethnicity, and so on. Things we won't be able to change with an intervention. Whereas the focus of our interventions will be on the modifiable, such as behavioral related one, and obesity and physical inactivities are then outcome measures of those. Or metabolic and intermediate risk categories such as impaired glucose tolerance, impaired fasting glycemia, and gestational diabetes mellitus also being then the outcome measures our interventions might be directed at. I already mentioned a little bit the second group amongst the modifiable risk factors or determinants, the more distant group, or more upstream as I like to call them. Those are the physical environmental related one, like whatever the obesogenic environment factors in your environment promoting obesity and decreasing physical activity, the policy environment promoting diabetes and other NCDs, the developmental environment, even if we look at international relations between different countries, which have a political and then also a metabolic consequence. Coming back to, before we start any prevention program, we should also be clear, why would we like to do that? Why should we prevent diabetes? The first argument was certainly the amount, the burden, the amount of human suffering we want to reduce, and that's why we recalled the statistics. Then also we want to prevent diabetes to prevent the consequences of diabetes, meaning the increased morbidity or mortality from diabetes related mainly cardiovascular disease, but also many other renal disease and other complications, blindness, and there's a whole catalog you should know about it. And then a typical public health argument is also you want to alleviate the economic burden diabetes is posing to societies, nations, but also to families, because quite often if there is not a sufficient healthcare coverage, and very rarely healthcare coverage includes preventive measures, then somebody has to pay for it, and quite often that could mean that significant resources of the family go towards dealing with diabetes treatment and complications. So those are three very good arguments why to prevent diabetes. Another more generic classification of diabetes programs or strategies is to group them into three levels. And I'm sure you heard about those levels already: primary prevention, secondary and tertiary, where the primary refers to preventing the disease, in our case diabetes, from occurring in the first place. In the secondary prevention, we have already the disease occurred, so those people have the disease, but we want to prevent complications. And the last one, tertiary prevention, we want to prevent worsening of complications, so those have not only the disease but already have complications. Quite often that means preventing death. Sometimes in the literature you find also the distinction of a primordial prevention, and that means intervention at the most distal point in the chain of causality, so standing even more left of primary prevention. Another way to distinguish different levels of prevention measures was published in 2000 in the obesity report by WHO, where they put at the center targeted prevention directed at those with existing problems, and in our case diabetes, around that selective prevention directed at those at high risk, and the largest ring called here universal prevention, directed at everyone in a community. In the literature you find very often this distinction into two parts: population-based strategies and high-risk population strategies, and that is also what we gonna use in part 2 when we look at those two different components in our presentation of diabetes prevention.